Good morning again. Wasn't that wonderful? Yeah. Helen will be here a little bit later. And there may be some time to have a Q&A. Next we have Dr. Ilan Linder from Israel, speaking to us about the Israeli experience treating paediatric epilepsy with medical cannabis. Dr. Linder studied medicine at Ben Gurion University in Beersheba, graduating in 1998. His postdoctoral education included residency and internship in paediatrics and later in pediatric neurology and child development at Edith Wolfson Medical Center in Holon, Israel, at Professor Tali Lemans-Sagi's Paediatric Neurologic Unit. Currently, he heads the Paediatric Epilepsy Clinic. His hospital work consists of consultations and specialised clinics such as the Catastrophic Epilepsies and Metabolic Genetic Neurologic Clinic. He teaches and guides medical students and paediatric interns and medical nurses the field of epilepsy. He also practices paediatrics and paediatric neurology in the community. Ilan first encountered the field of medical cannabis during his multi-centre trial treating paediatric epileptic patients with cannabinoid oil, extracts and vaporised cannabis. Ilan is a member of the Paediatric Neurologist Committee in the Israeli Ministry of Health, structuring guidelines for the use of medical cannabis in paediatric epileptic patients with oil extract and vaporised cannabis. So please give a warm welcome to our visitor from Israel, Dr. Ilan Linder.
Good morning, ladies and gentlemen. I'm very happy to be here in Australia once again with the kind invitation of Lucy and Lou, and on behalf of the UIC, and to say shalom and to welcome everyone here, all our dear friends that I've met last year at Sydney. I'm a pediatric neurologist, as I was just introduced, and I head the Pediatric Epilepsy Clinic at Wolfson Medical Center. And I'm also a member of the Israeli chapter of the ILAE, the International League Against Epilepsy. Last year, I talked a little about our joint experience in Israel, and I'll just get that through. Our joint experience in Israel regarding our registry of epileptic children treated by medical cannabis oil extracts and medical cannabis vaporization. The registry contains 130 children. And I will remind you of our results, and I will brief you in on some of the patients and the follow-up of 57 of them. Mentioned here are my colleagues, Dr. Michael Tzadok, Professor Uri Kremer, Dr. Moran Hausman-Kedden, Professor Buria Ben-Zeev, and Professor Tali Lemans-Sagi, which also appeared in the film before us, which we all collaborated in this study. I will also share with you some of our observations, reflections, and thoughts that are still we are left with today after 3 years ongoing with these trials. On a personal note, I studied medicine in the early 90s in Beersheba, in Ben Gurion Medical School of Medicine, which is actually the twin copy of an Australian medical school. And yes, cannabis was clearly a big miss on the curriculum. I think we were only exposed to it during the psychiatric rounds or during our visits in drug rehabilitation clinics, and that was certainly a big miss. This is the Wolfson Medical Center in Holon. It resides between Tel Aviv and Old Jaffa. It contains about 1,000 hospitalization beds, and is one of 6 hospitals in the center of Israel. Originally, I'm from Jerusalem, and this is where you see an aerial picture of the old city of Jerusalem. And on the right-hand side, you can see the 8 gates towards that are in the walls of the old city. Specifically, I would like to focus on the double closed gate, which is right in front of you, the gate of mercy and repentance, and I will come to that later on in my talk. About 70% of patients with epilepsy respond to one of the anti-epileptic drugs that are available today. We have nearly about 40 medications, and 30% do not respond. They are considered drug-resistant, or what was called in the past refractory epilepsy. Those who do not respond are faced with possibilities of further going into the regime of the ketogenic diet, or the vagal nerve stimulator, which is an implant on the vagal nerve to try and control the seizures, or any other surgical intervention. Our work, which was published originally in 2016, originally we referred to 74 patients. The CBD-enriched medical cannabis for intractable pediatric epilepsy, the current Israeli experience, was later on, as I introduced last year, contained 130 patients. It was basically an observational study. CBD-enriched oil extracts, and the study was, of course, approved by the IRB and 3 medical centers. It was a cooperation of these 3 centers in the Tel Aviv area. The inclusion criteria are listed here. Exclusion criteria included severe behavioral disorder, a significant family history of psychiatric background, or congestive heart failure. It is quite evident from the results that those included in the study, if we would try and give another medication, the possibility of succeeding in another medication would be near 0. As you can see, the vast amount of anti-epileptic drugs experienced by the patients. A vast majority of the patients were under 15. And as you can also see, the large proportion of them were intellectually impaired, about 92% of them. The age range was a little more permissive. As I said, it was an observational study. You see that there are patients here reaching the 32, very, very old children. The transitional epilepsy clinics do not actually exist in Israel, and many of the patient families persist on, and of course, we do not tell them to go away. Overall, we had an impressive about nearly 50% reduction of the seizures in about nearly half of our patient population, in 44% of them. Additional observations were that the seizures were of shorter duration, of milder intensity. Also evident was improved alertness and reduced spasticity. And as was mentioned yesterday, this had a follow-up with 2 more studies. One study is the autism study that began in Israel, and now we're taking another step further, another clinical trial with autistic children, trying to see any kind of benefit on their behavior with different strains of cannabis. And reduced spasticity, which was a study that was conducted by two colleagues of mine, Dr. Luba Blumkin and Ms. Stephanie Libson, which will be published very soon. They checked two concentrations, 1 to 20 and 1 to 6, in children with cerebral palsy, with very impressive results concerning the spasticity and dystonia. So look for this article in the coming months. The dropout rate in our study was nearly 30%, and the reasons were inefficiency of the medical cannabis or any adverse reactions. Of note, and highlighted in red, is that some patients did have aggravation of their seizures. Eight patients, which it was 6% of the population. The etiologic distribution was quite diverse, and you see that epileptic encephalopathy, the definition of which appears on the left, was by far the most dominant. Acquired etiology consisted of the CMV virus, cytomegalovirus, herpes virus, or the FIRS, the febrile infection-related epilepsy syndrome. The genetic epileptic encephalopathies consisted of CDKL5, for instance, that was also mentioned in the movie before, sodium channel 1A, Dravet syndrome, and others. You see that nearly a similar proportion of epileptic encephalopathy children had no genetic etiology. Structural malformations consist of agenesis of corpus callosum. I don't remember the other one, sorry. And also hypoxic ischemic encephalopathies. The adverse reactions are listed like somnolence, aggressiveness, irritability, or exacerbation of seizures, which were mentioned, and vomiting. A subgroup of our study population included children that were given medical cannabis vaporization, either with stationary devices or mobile devices. We were more strict on the exclusion criteria here. The hypersensitivity, any respiratory disease, cardiovascular disease, which was mentioned before that, mental illness was mentioned before that, and special considerations were taken into drug interactions like benzodiazepines, carbamazepine, phenytoin, and valproic acid, which are known to cause elevation of hepatic enzymes, affecting the medical cannabis effect. The response to vaporization was quite impressive. Out of 24 patients, you can see that the majority did respond in some way to the vaporization, but the group was very diverse, and we cannot draw any real conclusions from this response. Maybe a possible correlation to genetic epileptic encephalopathies, but it's a big maybe. So what has happened since last year? Well, bureaucracy is everywhere, and we had a bureaucratic standstill. There was a stop of permits, followed by a flood of permits afterwards after a very intense pressure from parents groups and from the media following that. But as regards to the vaporization, which was a very promising mode of delivering the cannabis, no parents were permitted under the age of 12. The main reason for that was the high bioavailability and the unknown effects, the long-term effects of the developing brain. We ended up following these patients in separate clinics, And I will present to you just a very short, a few slides of Professor Ulrich Remmers in the Tel Aviv Medical Center showing his follow-up. Initially, he had about 40 patients, and since then they grew to 57. So 40 patients overlapped the 130 initial that I presented last year. Their age range was quite similar, as you see. The intelligence is a little different. Out of the 130, the vast majority had mental retardation, while here nearly a quarter of the population had normal intelligence. The follow-up period was up to 33 months. And additional treatments were, as before mentioned, ketogenic diet and vagal nerve stimulation and epileptic surgery. Concerning the etiology, more or less the same etiologies that we encountered in the joint group, and also relating to the effect that medical cannabis had on seizures and the adverse reactions. Additional observations there was that only 4 patients were given above 20 milligrams per kilogram per day. You can see that the maximal dose given here, we reached the 800 milligrams before we only, the initial limit for us was 300. Actually, it was given later above 500, but over here we reached the 800. This was due to historical reasons. The FDA currently approved up to 50 milligrams per kilogram per day as the experience from Colorado. But where are the patients behind all these numbers and figures? So this patient is Oria, a patient of mine. She's 13 years old. She has no known etiology for her myoclonic epileptic encephalopathy. She is still on medical cannabis oil extract. She does not receive the vaporization due to respiratory problems. She's currently on 5 anti-epileptic medications, and she's also on a vagal nerve stimulator, and she's seizing quite a lot, but the medical cannabis alleviates the myoclonic seizures she has, and from the parents' point of view, it's a major contribution to their everyday living. Yuval and Talia. Yuval is the older kid. He had fires, and he much improved after the medical cannabis oil extract. He's currently on 1 anti-epileptic drug, and from a boy that was really doing very bad, he nearly returned to his everyday cognitive level prior to the fires. Talia has a very rare epileptic encephalopathy. It is the eukaryotic elongation factor 1A2. Only around nearly 30 people around the world have this. She's by far the youngest one of them to be diagnosed, and mostly they have a milder form of epilepsy. She was the parents reached us at the very early stage and insisted on medical cannabis oil to be put on medical cannabis oil. Actually, we declined at first, and we put her through the conventional anti-epileptic medications. She was given, I think, about 6 or 7 anti-epileptic medications, and she worsened tremendously on ketogenic diet. And then we gave her the medical cannabis oil, and she improved. She has epileptic encephalopathy. She has a very bad condition, but her seizures improved very much on the medical cannabis oil. Bar, the 70-year-old male, he has
dyscognitive seizures. His etiology is unknown. His mother is a herbalist, so she's treating him nearly by herself, and he's doing quite well on the one epileptic medication and medical cannabis oil and vaporization when he has his cluster seizures every 3 weeks, and they're much alleviated with the vaporization. Yotam is the 25-year-old on the right. He's currently not staying with his family anymore. He had a psychotic event. We do not really know if to relate it to the medical cannabis that he was being given, or to the Dravet syndrome or the other medication that he has. He's also been treated on 3 anti-epileptic medications, and he had a very strong and violent dystonic crises. Since last year, he had a very big deterioration. So, in regard to the patients that I'm familiar with, we had satisfactory response, but also we had psychosis, we had dystonia, we had catatonia, not in any one of these patients that I described to you now, but we had it as an adverse event of one of the patients from the 130 group. We experienced tolerance, we experienced reduced effectiveness and ineffectiveness. So, are we there yet in terms of the medical cannabis treatment? And as was put before me, are we tickling the giant? Are we just at the tip of the iceberg? Or are we playing the keyboards all at once? I rather prefer to relate to it as the monkey chase from Rudyard Kipling's novel, The Jungle Book. And I think we're now trying our best at many ways. We're treating, we're tickling, we're pressing, but not always do we know what we do. What other data exists concerning the pediatric epilepsy and medical cannabis? So just recently, in the New England Journal of Medicine, and Ingrid Scheffel, appearing in the movie, was one of the authors, the article by Davinsky and his colleagues. A multi-central, national, double-blind, placebo-controlled concerning the Epidiolex, the cannabidiol, with screening 100 patients with Dravet syndrome, children and young adults. They were given up to 20 milligrams per kilogram per day versus placebo, when the primary endpoint was the change in convulsive seizure frequency over a 14-week period of treatment after 4 weeks of baseline treatment. The conclusions of this study was that among patients with Dravet syndrome, CBD resulted in a greater reduction in convulsive seizure frequency than placebo and was associated with higher rates of adverse events. Also stated in the results, but not in the conclusions, is interesting to note that the patient's overall condition improved by at least category on the CGIC, the parental caregiver information, and this was statistically significant, 62% in the CBD group versus 34% in the placebo group, p.02. And this is quite similar to the results that we experienced in our studies and in other studies that are not RCT or double-blind. And the percentage of patients who became seizure-free was 5%, which is quite similar to what we had in our study. No significant change in the non-convulsive seizures. The meaning of that is that seizures that were no motor component, the staring seizures. So we're left with some questions and some observations that still puzzle us and raise some questions. I'm a clinician, I'm not a scientist. I rely on facts and figures. I rely on the work of scientists like Dedi Miri yesterday from my country. And we rely very much on the observations. The first question that I would like to pose is, are we treating correctly and at the right time? This is a wholly different situation here. This is a patient that was not treated with medical cannabis oil. This is a patient that was diagnosed very, very early, that presented very, very early. She presented at our hospital at day 2 of her life with some very violent seizures, and you can see her EEG on the very right, which consists of bursts and some attenuation, which is evident, even if you're not an epileptologist. And we performed a genetic diagnosis very early in her life. After about 1 week, we diagnosed her with SCN2A mutation. And because of that, she was treated with a sodium channel blocker, carbamazepine, which actually stopped her seizures altogether. Now, this is in line with a very interesting article that is stated here on the far left, which proposes the idea that there is some kind of window of time in these unique cases, a window of time relating to some kind of change that occurs in the neurons in the very early stages of life. This window of change allows us to implement the right therapy at the right time, and by this, alleviating the seizure load and the seizure intensity. Now, the neurological world has gone through some kind of a change of dogma, thinking in the beginning that if you would stop the seizures, you would also have a turning point in the development of children. Sadly, this is not the case. Those children that have genetic etiology do deteriorate as we go along. But for sure, if we can stop the seizures very early, we have some chance of giving them the chance for a better development and to improve their quality of life. Maybe this is the case also with medical cannabis. The example that we experienced ourselves with this very young infant, after giving her 6 or 7 medications that did not work, and medical cannabis did have a very large effect on her myoclonic seizures, maybe that's a small hint for us. Other questions. Do we need to implement some patient-tailored cannabis treatment, a sort of treatment that would implement also a correct genetic diagnosis, kind of an initial genetic screen, also with collaborations of the labs, performing this fingerprinting of the cannabis oil that Dedi Meiri presented yesterday, implementing these two together in order to treat the patients more correctly. Are we using the right diagnostic methods? Is the EEG, this is a very crude way of diagnosis and diagnosing what is happening in the cortex and only in the superficial part of the cortex, about 2 centimeters down the scalp. Is this the right diagnostic method to see what is happening concerning these kids that do respond later on to medical cannabis? Why is sudden withdrawal of medical cannabis therapy uneventful? We see sometimes we see the effects very quickly on as we go along. After about a week or 2 weeks, or sometimes even sooner, we see the effect. We do know that there is tolerance. We titrate up, but then sometimes patients tell us that in certain conditions they just stopped it altogether and nothing happened. Why is that? We need the international cooperation of data sharing. We're still just in the stage of pronouncing vowels. We haven't mastered our alphabet yet, and we certainly do not speak the language, well, at least yet. But it certainly works, nonetheless. Now, I promised you a little tale about the gate of mercy and repentance, what is called the Golden Gate of Jerusalem. What is common to Judaism and Christianity is that the Messiah will walk through these closed gates, riding, according to Judaism, on a white donkey. Heraclius, the emperor of Byzantium, returning the true cross to Jerusalem at 629 AC, tried to enter through this gate. It was common belief. What is the relation to epilepsy? I will just explain. It was common belief for centuries that because Jesus went through this gate, entering the old city of Jerusalem, that anyone that went through this gate would be cured of their epilepsy. Now, Heraclius, which was given the cross from the Persians, who we just won a war against, was beginning to enter the gate on his horse, and immediately the gate closed because only the Messiah could go through this gate, not on foot. So he went down, he went on foot, and once he went on foot, the gate opened for him. This is a beautiful painting by Miguel Jimenez from the 15th century, and it's exhibited in Saragossa. What is the relation to epilepsy? One is the tale that I just told you, and I'm not challenging you adjusting, but the quote in Latin is qua quoniam maximum virtutem adversus epilepsiae morbum dicitur habere, which says roughly, and this is from my father, who is a historian of medieval ages. I hope I'm not misinterpreting it. This is anyone who walks through these gates and suffers the incredible illness of epilepsy would be cured. Heraclius also had a familiar connection. His first wife, Fabia Eudokia, who died from epilepsy 2 years after she was married to him. She died from epilepsy. So he had any connection to this through the epilepsy. Allenby, General Field Marshal Allenby, knew this story, and you see him walking through the gate of Jaffa. This is not the gate of mercy. Through the gate of Jaffa into the old city of Jerusalem, he walked on foot. Unlike the previous Kaiser Wilhelm, who entered Jerusalem by horse and was very much disapproved by the inhabitants of Jerusalem. So Allenby was familiar with this, and it was much approved. This was the beginning of the British mandate of Israel, Palestine then. So thank you for attention, and I hope I shed some light on our experience with the epileptic children, the cohort, the Israeli cohort, and some thoughts that we have concerning this. Thank you.